And then you won't need to leave your video line on. We're really just using it to display the webinar, so feel free to mute your cameras as well if you desire.
Yes. I muted our camera. So I'm also going to mute myself until it's time for me to talk.
That would be great. Thank you.
Hello.
Hi there. Hi, this is Jeffrey.
Jeffrey?
Yeah. Oh, hello?
Oh.
I think we're getting some echo there.
Is that better, Jeffrey? It's Carrie.
Oh, hi, Carrie. Yeah, that's much better. We're just
Great.
waiting for folks to come on the line. We have a few people already.
Great.
Hi, everyone. I still see a few more names connecting, so we're just going to wait a little bit longer. Thank you.
So Jeffrey, should we It's 5 after. Should we get started?
Yeah, why don't we get started?
Great. Hello. Hey, was that Sylvia?
Yes, it is. I just
recognize.
joined
Okay. No problem. So we only have you guys for an hour, so I think we're going to go ahead and get started. I just want to thank, this is Carrie Sanders with CPEN. Just want to thank everyone who could join us today from the working group to finish our conversation about the
most workplace violence incidents result.
Just want to thank folks who could join us today for the call on the social determinants of health. I'm going to actually turn it over right now to Ignatius Bao, who is going to be facilitating this conversation. And he'll also, I think, do a brief roll call so folks can identify themselves and before we begin.
Great. So can folks hear me?
Yes.
Loud and clear.
Great. So welcome, everyone, and thanks again for joining to finish up the presentations and have some conversation about social determinants of health. So if we could just go and have folks go around and identify themselves as members of the working group, that would be great. Just say your name, and I think we know who you are. So.
Hi, this is Doretha Williams-Flournoy.
Hi, Doretha.
Hi, this is Tree Doe. I'm unfortunately going to have to leave in about 15 minutes. Hi, everyone.
Great. Thanks.
Hi, this is Cynthia Hernandez-Ganzi from Families USA.
This is Rakesh Patel from Urban Health.
So Sylvia and Rakesh. So let's do the working group members first, and then we'll have the families and CPEN staff introduce themselves. So other working group members? I saw Peter.
Virginia Hendrick with Louis.
Hi, Virginia.
Frida, LA County.
And Kristen, are you on? Margarita, do you want to introduce yourself?
Yes, I'm not sure.
So we can barely hear you, but we're glad you're able to join us. Great. And then Families USA staff?
Cynthia, you want to go first? Okay, this is Sophia Tripoli, Families USA. Also in the room with me is
Raven Gomez, Families USA.
And Cynthia is also on. And Hector, do you want to introduce yourself?
Oh, you want to introduction? Okay, sorry. Yeah, this is Hector Flores, White Memorial Medical Center.
Great. And Peter, have you joined us now?
Hi, this is Peter Long, Blue Shield of California. Good afternoon.
Great. All right, and then Carrie has introduced herself. We are about to introduce Jeffrey. Aviva, do you want to also introduce yourself and other CPEN staff?
Sure. I'm Aviva. I'm CPEN's IT and Operations Manager, and I'll be advancing slides, and if there are technical issues, feel free to send them my way. I'll be keeping tabs on the technology.
Great. Thanks, Aviva. So,
great, and I'm, sorry. Go ahead, Ignatius.
So I was just about to introduce Jeffrey Coe from the CPEN staff to lead us off on the overview of the findings and research based in California, and then we're going to turn to Sophia from Families USA to do the national presentation. So Jeffrey, take it away.
Great. Good afternoon, everybody. I'm Jeffrey Coe, Grants and Projects Coordinator here at CPEN, and this is quick overview of our work on prevention and social determinants of health in California. Next slide. So just as a quick starting definition, what is a social determinant of health? The social determinants are the circumstances in which people are born, grow up, live, work, and age that affect a wide range of health risks and outcomes. These circumstances are shaped by the unequal distribution of money, power, and resources. Next slide. And right now in California, healthcare stakeholders are trying out a lot of different approaches to advance prevention and community health that are really thinking about the role that social determinants play. And in this work, clinical and non-clinical stakeholders are both coming together to try and figure out how can they address the upstream social determinants of health. Next slide. So I wanted to start off with two key findings before taking everyone through a brief survey of California's prevention efforts. Firstly, we found that prevention work amounts to an evolution of the healthcare system's functions and responsibilities. Historically, we had a volume-based system based on fee-for-service architecture that created a financial incentive to provide services, but not necessarily to maintain the health of patients, and usually not to provide services that address the social needs of patients. Currently, the system is really moving towards value-based care with a prevention focus. So we're seeing the introduction of payment reforms and clinical practice shifts that focus on patient health as opposed to service volume. But in addition, the healthcare system is starting to think about how it can directly address the upstream social determinants of health, things like housing, food and air quality, the conditions that we live, work, and grow in. These factors are hugely impactful on health, but can't be addressed through traditional clinical approaches. They require non-traditional interventions, things like affordable housing, food pantries, and even legal aid. And there are two approaches that we saw when looking at what's going on in California. Firstly, the healthcare system can coordinate with non-clinical payers and providers, such as social service agencies and community-based organizations. The healthcare system can also start actually directly paying for and delivering this kind of non-clinical care. And these two approaches aren't mutually exclusive of each other, but both recognize that health is not limited to clinical factors, and in fact, recognize that even non-clinical services may be medically necessary to improve a patient's health. Next slide. And secondly, closely related to our first finding was that it's important to tie together these clinical and non-clinical approaches. Both clinical and non-clinical systems are doing a lot of work to support people and individuals, but the healthcare system is really thinking about how we can tie together the two areas. Clinical providers are in a good place to identify patients in poor health who might benefit from social services, but it's the non-clinical providers who hold that key piece of doing the work that addresses these social determinants. And as coordination improves, patients are more likely to have their needs met. Next slide. So going back to what we're seeing taking place across California, this is a pretty broad survey, and it cannot necessarily be 100% all-inclusive because of the sheer diversity of local work, but we hope that this is a helpful overview. Within clinical systems of care, there's some work being done around prevention. In the Medi-Cal 2020 Section 1115 waiver, there's both Prime and GPP, which are creating new incentives and reimbursement structures that encourage the delivery of value-based care in public healthcare systems. Within community health clinics, the Pray-Pair survey is basically a social risk survey that can be administered to patients, help community clinics assess what are the needs, and help develop care plans that address the social determinants of health outside the clinic walls. Whole Person Care, also a Section 1115 waiver pilot, provides counties with support to develop care coordination infrastructure that bridges health, behavioral health, and social services to better deliver care and reduce costs for the highest cost Medi-Cal patients. Next slide. There are also some alternative models for prevention and care that are taking root. For example, virtual dental homes are bringing basic prevention and therapeutic oral health services to community settings where people who don't normally have access to oral health care can get them. And they're also using technology to connect patients to remote dentists. pending legislation, California Senate Bill 207, which is actually a CPEN-sponsored bill, would permit Medi-Cal to reimburse for education and in-home remediation for asthma provided by community health workers. And a lot of these services are non-clinical in nature. Education, helping patients obtain the resources they need to keep their homes free of triggers, and removing asthma triggers from the household. Next slide. And there are also approaches to prevention that are cutting across traditional notions of what's clinical and non-clinical and bringing together diverse stakeholders to support a community's health needs. The California Accountable Communities for Health initiative is supporting collaboration between health payers, clinical providers, and community-based social service providers in a community to coordinate what's called a portfolio mutually reinforcing interventions to address a community health issue. And the hope here is that when providers, payers, and social services work together, they can have a greater impact than they would when they're working independently. There's also Health in All Policies, which is bringing together 22 different California departments and agencies to advance health equity-focused planning and policy development that addresses the social determinants of health. And importantly, this includes non-traditional partners such as Caltrans and the Department of Corrections. Next slide. And so this here is the matrix that we've used for much of this assessment. And while I think it can be helpful, I also want to point out that assessing prevention can be a little tricky because a lot of it takes place outside of the delivery system. So delivery system focused criteria don't always capture the full nature of what's going on. It's also true that a lot of these efforts are pretty young, and we're still waiting to see how successful they can be and trying to figure out the best way to assess their success and articulate their value. Next slide. So I just wanted to go over some key takeaways. Next slide. So in addition to the two takeaways that I opened with, there are a couple more that I wanted to review. Firstly, within the healthcare system today, payers and providers are challenging themselves to define health more broadly and to take on prevention. For payers, there's an opportunity to create new payment schemes that incentivize patient health over service volume. There's an opportunity to also provide flexibility to allow the use of services that address the social determinants of health. And payers also are in a position where they might be able to help coordinate a lot of this work, since they're already tracking patient encounters and have some of the infrastructure that could be leveraged to strengthen this coordination. On the other hand, we have providers who are carrying out the day-to-day work of prevention, as they're working directly with patients to deliver the care they need. And they're also in a good place to assess the social risk factors that impact health of a patient. And in coordination with social service providers, they can help develop care plans that address the social determinants of health. And then as non-clinical providers are brought into the healthcare system, there might be an opportunity also for providers to directly actually address these social determinants of health. Next slide. And then not all prevention takes place in the healthcare or social services. Right? Policy-making entities have a key role to play in this work. As we saw in Health in All Policies, the state can coordinate work between government entities and make sure that non-traditional partners can consider the impact their work has on health and prevention. And this is really important considering how impactful the upstream factors can be on the health of communities. The state can also conduct broad and holistic strategic planning that considers the totality of factors impacting health and bring together a wide variety of stakeholders to develop strategic plans. For example, there was the Let's Get Healthy California Task Force, as well as the California State Innovation Model, which, although it was unfunded, did help lay the groundwork for the CACHI today. The next slide. My last takeaway is that prevention work is local and diverse. The specifics have to be local and diverse because communities are local and diverse. Many of the programs mentioned earlier allow funded entities discretion in how they address the issues that they're tackling. For example, GPP and Prime set incentives and payment structures, but gave public healthcare systems the ability to determine the best strategies to achieve those goals. Likewise, CACHI relied on a local collaborative that would determine the specific issue, find the participating members in that collaborative, and develop the portfolio of interventions. Next slide. And then lastly, some suggested areas for future research. And we're really interested in hearing what the working group has to say on this area, especially because many of you are involved in this work and a lot of it is so new. As we look at how these current prevention efforts pan out and talk about the future, here are some questions we want to consider. Short term, what findings and best practices are emerging right now from the current prevention work taking place across the state? And then what other models should the state consider to advance prevention? And this is a question that our partners at Families will also talk about in the next presentation. And then in the more long term, we're curious to know what role healthcare entities can play in addressing community issues like housing, violence, air quality, and food access, how California can finance community prevention, and then also what role do healthcare payers play in this work going forward? Should they be incentivized to invest broadly in the social determinants of health, including those outside of their covered lives? And with that, I would like to pass the baton on to our partners at Families USA, who can give us a survey of what's going on across the nation in this work.
Awesome. Thank you, Jeffrey. This is Sophia, and I think, Cincy, you're going to take it away first and then hand it back to me.
Yes. Hello, everybody. We wanted to start off our part of this presentation with a little bit more grounding in social determinants of health, especially as it relates to issues of race and racism and geography, to get a broader picture and understanding of some of these efforts. Next. So some of you may have seen this is from the Kaiser Family Foundation. We find this to be one of the best descriptions of the spectrum of determinants of health that we're talking about. And one of the, we really appreciate the way that it lays out all these different basic, which sometimes are silos of influencers of health. But we did have, especially from thinking about from the health equity perspective, some important amendments to this framework. Next. So where you see that there was food, we really need that to be broader to include physical sustenance issues, including things like clean air and clean water, basically what it is that people are having or able to put into their bodies. The other issue that we wanted to highlight is that in this framework, discrimination only shows up in the community and social context. Next. And what we know is that in reality, the realities of systemic and structural discrimination and racism mean that next, discrimination is also an important factor in all of the areas that have been identified as categories of social determinants of health. And then on top of that, where we end up is that when we're thinking about how the healthcare, these questions that were just presented of how should the healthcare system, which is all the way to the right of this picture, intervene and ameliorate these issues across the rest of the spectrum, we also have to be very cognizant of the fact that next, the healthcare system is really only responsible for maybe, actual healthcare for maybe 10 to 20% of health outcome. So that means that we need to, first of all, it's the case for why we can't simply only look at what's happening within the walls of clinics and hospitals, that we have to, if we really want to move the needle, not just in the spectrum of social determinants of health, but in particular on issues of racial inequity, we need to be able to connect farther, farther left on this picture, or what some would say farther upstream. Next. Want to review really quickly that the impact of discrimination on health is multifold. Obviously, there is the impact directly on the individual, the physiological and psychological effects, which we know from ACEs research, from toxic stress research, from research on allostatic load, that it actually affects your physiology beyond just being stressed out, right? It can even affect your DNA. And in addition to that, then you're in a situation where you are at higher health risk because of the social determinants and structural racism, you have lower health opportunity, less access to positive things for health. And then when you actually are sick, then you have to deal with the bias in the healthcare system. Next. And in this country, we also have to understand that there is this overlay of the realities of the persistent racial and residential segregation that continues to exist in this country, and how that concentrates. So when you talk about poverty and health risks being concentrated, and communities not having being under-resourced when it comes to health and healthcare assets, what you see are very, very big difference by zip code, which, because of segregation, means that we're also seeing very big differences by race. And so the upshot of this is that we have to really understand that to make a real difference in equity, we need to be looking at community level interventions, because that is where, in some ways, one way of thinking about it, where a lot of the damage and risk is happening. Next. What that means, though, is that if you're looking at how, in this question of how far up in terms of social determinants or upstream factors we think is appropriate, or we should consider appropriate for healthcare systems to invest in and get involved in, you see that there's a broad range. You can either, there are organizations that are working directly on basic fundamental social determinant challenges like violence and food insecurity and under-resourced schools and unemployment. And then you have all of the issues that still need to be addressed within clinic walls, like uneven quality, the fact that the evidence base that we have for equity for different populations is very limited, language access, implicit bias, all of that. The question here is, how do we believe that hospitals and clinics should be working specifically on, increasing language access, teaching English, versus a middle ground, this bridge between what is clinical and what is community, where we can address where the healthcare systems really do have a lot of opportunities, not necessarily to eliminate the social determinant barriers, but to ensure that those social determinant barriers don't have a disproportionate effect on health and being able to access health. So, for example, we have a problem with non-emergency transportation. We're not talking about hospitals buying people cars. We're talking about what can hospitals do to provide bridges between communities and hospitals in terms of transportation, right? So this is a very important, it ends up being hotly debated in policy circles. Like, do we really want hospitals to get in the business of X, Y, or Z social issue, or in the business of housing? And I think one way to look at this is not necessarily, but what we do want is to make sure that they are investing in in the kind of interventions, partnerships, resources, and services that help reduce the impact of these deeper social determinant barriers. Next. So that's basically the background, the way that Families USA has been thinking about social determinants of health as it relates to health equity and race. And now I'll shoot it back to Sophia, who I think is going to lead some of the review of the research that we did on what's exactly happening at the national level and some examples of what's happening in different states to address social determinants, which aren't always necessarily just seen as preventative services. They can be much broader than that.
Thank you very much, Cincy. Thank you so much, Cincy. So just as Cincy mentioned, I'm going to just take you through a couple of sort of what we wanted to just highlight as some interesting and promising models across the states in terms of addressing social determinants of health in the context of system transformation. So first, one of the programs is actually sort of unlike the others that we looked at is the Racial and Ethnic Approaches to Community Health, the REACH program, which is a longstanding CDC grant-funded program where CDC funds grantees to carry out local, culturally appropriate programs to address a wide range of health issues that cut across 4 target areas: tobacco, nutrition, physical activity, and community clinical linkages. Next slide, please. What's interesting about the REACH program is, I think, just in terms of their impact, as you'll see here, they have sort of a some pretty impressive numbers in terms of the services delivered and the impact of the program. But important to point out that these aren't health outcomes. So there's not necessarily a strong correlation between the REACH grant program and specific health outcomes within each of these buckets. But in terms of overall impact of REACH, 2.7 million people having access to healthier food and beverages, over 500,000 people benefited from tobacco-free interventions, et cetera. So wanted to sort of just highlight this as a national sort of CDC-funded program. Next slide, please. So the first state to just highlight is the North Carolina Medicaid transformation work, which just as a reminder, folks, the General Assembly in North Carolina enacted legislation to transition the state's Medicaid program from fee-for-service to managed care. And their Department of Health submitted and Human Services submitted an 1115 waiver in November of 2017 to CMS, which was actually approved in October of 2018. And so the key component in the Medicaid transformation work in North Carolina are their Healthy Opportunity Pilots, which is up to $650 million in Medicaid funding over 5 years for the life of the demonstration to cover the cost of select services related to 4 domains: housing, food, transportation, and interpersonal violence / toxic stress. Next slide, please. Important to point out with the North Carolina waiver is that this waiver was approved under the Trump administration. So just keep that sort of in the back of your heads. And under these pilots, the managed care organizations are allowed to pay for CMS-approved evidence-based interventions that address housing instability, food insecurity, transportation barriers, and interpersonal violence and toxic stress. This is pretty groundbreaking for Medicaid and for CMS to approve, and so I think that's just an important note. I'm sorry. Can you go back one slide? I apologize. There's one other point on the North Carolina Medicaid is that to be eligible for the pilot services, enrollees have to have at least one needs-based criteria and at least one social risk factor. So they're in the early stages of implementing the transformation waiver, so it'll be interesting to see how this plays out over the life of the demonstration, but definitely a model that I think we want to track, particularly in terms of the social determinants of health and the impacts of the Healthy Opportunity Pilots. Next slide, please, back to Massachusetts. So the next slide, the next state to talk about is Massachusetts. You'll remember that Massachusetts has an accountable care organization program that leverages $1.8 billion through its Section 1115 Medicaid waiver demonstration over 5 years. It has 17 ACOs. There are 3 different ACO types. We talked about a lot of that when we were out in California in May, so I won't go into too much detail. But what's important to note here is through their accountable care organizations, there are some specific care delivery features that are that we wanted to point out that really emphasize a strong focus on individual needs, better care coordination of services, and attention to health-related social needs. So a sample of that are care needs screenings and comprehensive assessments, which are required to be completed within 90 days of a new member joining. They're looking at health-related social needs. There need to be culturally and linguistically tailored and appropriate services. And so that's one feature. Another are the community partnerships. Community-based organizations are partnering with behavioral health and long-term services and supports. And they're providing sort of care coordination, navigation supports. And so the impact there for community partners is around 20,000 to 24,000 members. So that's another piece. Next slide, please. And then the last piece on Massachusetts to point out are that the flexible services. So the ACOs are tasked with addressing health-related social needs by providing non-medical supports and services. And so they're looking at, through their sort of the district part of the waiver, things like pre-tenancy, sustaining tenancy, home modifications where needed, and nutritional support. Next slide, please. And the sort of third state sort of promising model is one that you're familiar with, the accountable communities of health, the Washington sort of model. You know, the ACH in Washington is part of their Medicaid 1115, you know, big transformation waiver, and they're designed to address, ACHs are designed to address the social determinants of health equity through regional organizations that include community-based organizations, housing, and human services. And so this is sort of the slide, a sample of the measures that are starting to get at the social determinants of health, and I think you can see that there's more work to be done, but looking at percentage of homeless, they're in the process of developing their specific health equity measures as it relates to social determinants of health for each ACH, so that will be interesting to track and to see how that plays out over this next short period of time. Next slide, please. So just some key takeaways to run through. First is that addressing the social determinants of health is a primary goal of all three of the initiatives, that the state models that we just ran through. And the move to Medicaid, the move to have Medicaid pay for housing and food services is tied to managed care, so that's an interesting, I think, takeaway. Community-based organizations are included in the regional governance structure. And then to address the social determinants of health, these models focus on screening for adverse determinants, building stronger linkages with community-based organizations, and or paying for sort of what's called flexible services. So those sort of non-traditional clinical services that can address and really get at the social determinants of health. And then I think importantly, particularly in the North Carolina model, food insecurity, housing instability, and safety and domestic violence are targeted and are actually common across these three sort of big Medicaid transformation waivers. Next slide, please. And I think just the last thing here are just some questions for us to consider, for the work group to consider through our discussion now, I think, which we'll have for the remainder of the time, and sort of further research that we might want to take up. And with that, I will turn it over to Ignatius.
Great, thanks Sophia and Cincy and Jeffrey for the great overview. A lot of information to cover. So I just wanted to acknowledge any additional working group members that didn't introduce ourselves. Kristen, I think you've joined us.
Yes, can you hear me?
Yes, thank you. And any others that I missed? Great, so let me just open up in the remaining time that we have about 20 more minutes in the call for folks to either ask questions of Jeffrey, Cincy, and Sophia, or to suggest some additional areas of research. A lot of this, as they all noted, is still relatively new, so that there may not be strong outcomes other than the kind of preventive services outcomes in the REACH program, but we welcome your input and your questions. So let me just open it up for whoever has those questions. Sylvia's already put one in the chat. So Sylvia, do you want to raise your point?
Hi, sorry, I'm just changing myself in and out of mute, apparently. So I wrote it in there, and now the chat box has disappeared. Basically, and it may be somewhat answered as you went on, but I was wondering whether, when you said these are managed care organizations that could be and are addressing social determinants of health, is that because additional money is being put into the capitation rate to address social determinants of health, and they're expected to say what they're spending on and what the outcomes are, or is it that they're allowed to, but there's been no change to the capitation rate?
So, Sophia, do you want to take that one?
Yeah, so I'm assuming that's across North Carolina, Massachusetts, and Washington. And I would say there's a little bit of variation depending on the financing of the waiver in each state and the sort of negotiations between CMS and the state and what sort of ended up in the final the final DSRIP or financing of the waiver activities. And I believe in all three states and all three examples, it's particularly in North Carolina, there's a requirement to address the social determinants of health. So it would be built in newly to the financing of the waiver over the 5 years.
Okay. Yeah.
But I'm not, Sophia, I'm not aware of any of these programs that are actually tracking those costs separately. I think Sophia's question is then, would they rebalance or readjust a capitation in future years? And I don't think any of the plans are being asked to actually track those costs.
I understand the question now. No, that's exactly right, Ignatius. That's my understanding as well.
Okay. This is Kristen. Are you taking calls on the or taking questions on the calls, or just by those that are being submitted?
No, go ahead, Kristen.
Okay. Two questions. A sort of a follow up on the last question by Sylvia. Is it and I think this probably relates mostly to North Carolina's situation, but do you know whether they made some adjustment in the rate, the capitation rate, to account for any hopefully reduction in healthcare costs as a result of an investment in social determinants like support services? Because of I guess what they call the premium slide.
Right. Let me look into that. I don't think so, but let me circle back and confirm, and then we can maybe figure out how to disseminate an answer to that to confirm it. Unless there might be someone else on the line who might actually know the answer, but I'd have to go back and look.
Okay, great. Then the other question I had was I was kind of intrigued by your further research questions at the end. The last one is, are there measures for equity performance, and are there examples of where they are tied to social determinants of health?
Cynthia, do you want to take that one? So I can start. So from our research, from the assessments that we did, they're in the case of Washington, for example, they're under development, and so I think that'll be a similar case in other places.
Hi, this is Cincy. Instead of unmuting myself, I disconnected myself. Did someone answer the question? I apologize.
So Sophia just said that in Washington, the equity measures are under development, but I don't know, Cincy, if there are other examples that you want to raise for folks or not.
So I know that there's been a lot of work in trying to develop equity measures, and I think maybe even Ignatius could speak to that with the work that's been done in the National Quality and NCQA, et cetera. I am not right now aware of any program that has integrated equity measurement in their work.
So this is Ignatius. The only one that I know specifically is in Oregon, that they had a lot of discussions in their Medicaid coordinated care organization program, whether or not they should adopt a separate equity measure as part of their bonus payment incentive measures. They went round and round, and they ultimately adopted that currently is in place a measure that is reducing unnecessary emergency department utilization for people with mental health conditions. And so it's a subset of the larger, reduction of avoidable emergency department utilization. And so it requires them to stratify that data out by individuals on Medicaid with mental health conditions. How that measure is going and how they're doing on that measure, check back in. That's the only example that I know.
Can I ask this is Cincy. Ignatius, can I ask a question about that? So
sure. I
understand about that they need to stratify the results, but is there supposed to be, depending on how the results get stratified, on the results of the stratified result, data, is there supposed to be will there be a bonus payment if
Yes.
you find that you
so
do
similar to the other incentives, there are benchmarks that they set based on the data that they had looked at historically, and if they don't make improvements, they don't get incentives.
Got it. Thank you.
Ignatius, this is Jeffrey. I think I would just add to that in California, the PRIME program does have a disparities reduction pilot that does ask participating hospitals to identify an existing disparity and then demonstrate progress in closing that disparity to draw down some of the incentive money for that project.
And that's related to hospitals? I'm sorry, this is Doretha.
Yeah, so that's for public healthcare systems, so usually large public hospitals.
Or any other hospital that's in a disproportionate share, right? It doesn't have to be public. It has to have a disproportionate share of indigent people that attends it and has that designation. Is that correct in California?
As I recall, and I can circle back actually, the participating hospitals are public and district municipal hospitals. I don't think it covers any private hospitals.
Yeah, this is Hector. Those are exactly, the PRIME program is earmarked to those institutions, the public critical access and district hospitals.
And is this information written in a document that's public that we could just sort of Google and learn a little bit more about the PRIME program and their equity performance measures?
So Doretha, in the shared drive, we've done much more detailed descriptions of each of the programs, including the PRIME program, and that should be there.
Great.
And
I sit on
additional references to the sources that we found.
I'm currently sitting on a working group that's developing some proposals for a new healthcare system or a re-envisioned healthcare system in California, the CHRI. And CPEN was previously on this committee, but they have, developed a group of proposals, and they have healthcare targets. And within the healthcare targets themselves are strategies that reduce cost, improve and ensure healthcare quality, and increase access to coverage and care. And they have within that framework, within each of those targets, a health equity framework that they believe should be applied to all of the targets. But it seemed to me that the targets were somewhat limited. The targets were, all of the targets should be monitored by income, race and ethnicity, gender, region, insurance type, and other characteristics that are related to reducing disparities, but they don't venture into the social determinants of health. So I think it's really important to sort of create these equity performance measures that could be then adopted by these types of initiatives, or at least given as examples to these types of initiatives so that they can incorporate this into their thinking as they're moving forward with making recommendations for a different type of healthcare system here in California.
Great, and so feel free to follow up with any of the CPEN staff or the Families USA staff if you want more detail, especially I would think some of these other models that Sophia shared from North Carolina, Massachusetts, and Washington might be really important to look at.
Great. Is it possible to resend the link to the drive out to the committee, or at least to me, so that I can find it easily and hopefully save it? So.
Absolutely.
Thank you.
So other questions from other working group members or
comments?
All right,
this is Margarita. I was also intrigued by your question regarding the potential for further, evaluations. One of the areas that I'm very interested in is if anyone is looking at the use of technology and leveraging technology to be able to do the appropriate outreach or facilitate resource linkage, for either housing or, food, wellness programs, a variety of programs that would address the social determinants of health. And one of the things that's, I think, frustrating is that even though there are studies out there that show that people with lower incomes or people whose first language is not English do use technology, whether it's just a mobile phone or social media such as Facebook, there's still a lot of perception within our, system and providers that perhaps these individuals are not using it as much. And we don't put the support and the resources in at the local level. I can say for LA County, for example, we've had a real difficult time getting people to just even engage on the portal and the electronic health record. So we haven't done anything really to facilitate them, right? So one thing is to use the technology because it's already there and easy to use, like Facebook. The other thing is if you're having to go in and get an app, download it, get the password. A lot of people might not have an email, but helping them facilitate that and then having them leverage the wealth of potential applications that are out there. So that's one thing. And then the second comment would be that would be a way for us to be able to leverage public-private relationships, right, where there are a lot of kind of social justice-focused individuals who might be working in the private sector, whether it be a foundation or technology, who might be interested in funding this type of work, but they don't really know that there's evidence behind it or that there's been the evaluations you're starting to do around, addressing the social determinants really have improved outcomes. And I don't know if I'm making sense in connecting those two things, but I'm really, I think we're leaving potential very rich resources on the table for people just because they're poor or don't speak English or they might not connect the dots themselves.
Great. So thanks so much for that comment, Margarita. That's definitely a theme that has emerged. We haven't sort of called it out explicitly in the research. I do know from going to these conferences called Health 2.0 that I'm always looking for examples where the technology is being leveraged explicitly around equity issues. And there's not a whole lot of examples, but that's definitely something that we should add to the research agenda that we're developing as we look at these issues more closely.
Ignatius, this is Sophia. If I could just say two really quick things about that, just sort of from the national perspective to throw in the mix. I completely agree. I think we can go back and look. But two things that folks might already be tracking, but in case you're not, there was a recent rule from CMS about exactly that, making healthcare data, requiring healthcare data to be shared through apps to give consumers access to their healthcare data, et cetera. And so it's not necessarily with an equity lens, but something to track and that we're tracking here at Families and happy to share with folks as that's finalized and what the impacts might be. And then the second thing is along the same lines, there's a healthcare bill that just was voted out of the Senate Health Committee today that includes a congressional sort of version of the proposed rule, a little more limited in scope, but similar concept, and then also funding to help local health departments build their health technology infrastructure. And so those are just two, I think, pieces that we're tracking here and happy to share back. But I think if we're to move forward, the rule, if it's finalized, depending on what it looks like, could have some pretty significant implications for a lot of the areas that you just addressed.
Thank you. That's really great. Can I just add one little additional lesson learned, I think, for us in Los Angeles, at least for me, and I'm in the ambulatory. I was in corrections and now in ambulatory in LA County. Is that, even when those technologies are available, what we lack are the resources to be able to facilitate that for the consumer, for the patient. And I think a corollary to this is, people need to get their birth certificate in order to get an appropriate ID, in order to be able to get to apply for, for public services, right? And we have put monies to helping people actually get that birth certificate or proof of citizenship or whatnot. It's the same as that I'm finding in our population where people are like, yes, I would gladly use this app or your portal. Oh, but you need an email address. Oh, do I trust an email address? I don't know how to get an email address. I've never had an email address, and so so that simple linkage, but that resource also to be able to fund some of that frontline staff, community health worker, peer support people that actually do that linkage would be important as well to look at.
And this is Cincy, and that's a really intriguing idea. I can tell you that looking at some of PCORI's research on, they have a telehealth portfolio, and there they really were looking at some of the factors that were important for certain communities, especially communities of color and low-income communities. Is, for example, not assuming that people have access to an actual computer, not assuming that people have that, an app may not be the best way to be able to engage when people may not have smartphones. They may just have regular cell phones. So, and then there's, of course, continuing serious issues with broadband redlining and the lack of broadband access and so forth. So I think it's a very, very important area to look at, but it's also an area that fundamentally, like structurally, has some inequities within it that we would have to kind of plan for and account for.
That's right. Very, very. Thank you for bringing that up, because it's exactly. I mean, people come into our clinics and we have guest Wi-Fi, and it's amazing what happened, right? When guest Wi-Fi gets turned on, it's so. You hit the nail on the head. Thank you for bringing that up.
Great. So we knew we would run out of time, so I'm going to thank everybody for the presentations and the comments. I encourage people to do any kind of follow-up questions or comments back to Carrie, and we will follow up as we are going to reconvene as a team to think about the next phase of research. But let me take the last and turn it back to Carrie to see if she has any final words.
Could I just ask something? This is Sylvia. And when you say you'd like some follow-up, if we didn't get opportunity to say something, do you want it just to be written to you as a team or to Carrie, or do you want it to the entire group? Because it's kind of useful.
If you could just send it to Carrie directly, and then we'll circulate it.
Okay.
Although I hear what you're saying, Sylvia. So everything that you share with us, we'll be sending notes of the call out to the group so that folks can see, what other folks are saying. And if you want to talk offline about, platform or a way to continue discussions as a working group, we can also look at that as well. So I'm happy to follow up with you. I think that's an interesting thought. I know we're at the. Yeah, no, thanks for raising that. I know we're at the end of the hour, so as Ignatius said, we don't want to keep you too long or late, but we are kind of now entering the conversations of where we want to focus our research. So if you do have further questions, or as we're calling them, research questions that you are thinking about in this area of the social determinants of health, please do forward them to me so that I can share it with our two teams. We will be, looking at all of those, trying to incorporate your feedback as we determine, sort of next steps for ourselves and our research. And we will we do hope to bring back, some initial, ideas and findings to you all later this summer. So we'll be continuing this conversation with you all, not just on social determinants, but on all of the different other areas that we are focused on as well. So thank you again. Thanks to our speakers, and thanks to everyone who was able to join, and also thanks to Ignatius for facilitating. Hope you guys have a great day. Thanks again.
Thank you.
Thank you.
Thank you all.